You walk into the patient's room, and the alarms are just going off everywhere. Your patient is super agitated, they're profusely sweating, and they're screaming that they have 10 out of 10 pain. How do you actually tell the difference between a patient in legitimate, undertreated pain, somebody who's intoxicated, and a patient who is entering a life-threatening withdrawal?
I mean, that is genuinely one of the most high-stakes puzzles you are going to face in clinical care. The signs heavily overlap, they mask each other completely, and if you misinterpret them in the moment, the consequences for the patient can be fatal.
Welcome to an episode of the Super Nurse Podcast. Now, just to be clear up front, we are not Brooke Wallace.
Right. No, we definitely aren't.
Brooke is the creator of this show. She is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
Yeah, we are essentially just borrowing her brain today. We're using her bedside knowledge, her personal notes, and her teaching style to really help nursing students and new nurses apply what they know to real patient care.
Exactly. And before we get too deep into it, make sure to invite your friends to subscribe, and you've got to watch the comic book-based videos on YouTube. The link is in the description on our channel called Super Nurse Comics.
It is super cool. Highly recommend it.
So our mission today is to translate all this dense medical literature into practical, rapid-fire pattern recognition for the bedside. So let's just jump right in. When you walk into that room and the alarms are dinging, what are the very first physical clues you're looking for?
Well, we start with the eyes. Pupils are a massive bedside clue that you can assess in like 2 seconds.
Literally just a quick flashlight sweep.
Exactly. What clinical experience and research show is that pupil size gives you a direct, unfiltered window into the autonomic nervous system. So, constricted or pinpoint pupils are the absolute classic sign of an opioid overdose.
Right, they look like tiny little dots.
Yeah, and when you see pinpoint pupils combined with slow, shallow breathing, and we're talking fewer than 8 breaths per minute here, that is a massive red flag. It requires immediate intervention.
And on the flip side of that.
Right. On the flip side, dilated, very large pupils typically point to stimulant use, so things like cocaine or methamphetamines, or they can actually indicate acute withdrawal.
It's really all about pattern recognition, right? Toxidromes.
Right.
And maybe before we go any further, let's just clearly define a toxidrome for anyone who hasn't heard that term since, their first pharmacology class.
Yeah, that's a good idea.
A toxidrome is basically just a toxic syndrome, right? Like a specific cluster of physical symptoms, pupil size, heart rate, skin temperature, respiratory rate, that acts as a fingerprint for a specific class of drugs.
That is a perfect way to put it. It's a clinical fingerprint. If you can read the toxidrome, you often know what drug class is causing the crisis before you ever even get a lab result back.
Which really brings up alcohol, because the toxidrome for severe alcohol overdose looks incredibly different from someone who is just, everyday drunk.
Oh, it is a totally different physiological state.
Mm-hmm.
Severe alcohol intoxication is a literal medical emergency that looks a lot like shock.
Wow, really? Like shock?
Yeah. You are looking for extreme hypothermia, a dangerously low body temperature, because alcohol causes massive vasodilation. It just dumps the body's heat.
So they're going to be freezing cold to the touch.
Freezing cold. The skin will be pale, bluish, and really clammy. Their respirations drop, the heart rate drops, and crucially, they might lose their gag reflex entirely.
Oh man, that missing gag reflex is terrifying for a nurse. If they vomit, they can easily aspirate right into their lungs and choke.
Exactly. It's an airway nightmare.
Now, I'm trying to wrap my head around the workflow here at the bedside. If someone rolls into the ED or they crash on the floor, my first instinct as a newer nurse might be to immediately run a urine toxicology screen. Like, why not just let the $1 million hospital lab tell us exactly what's wrong?
I am so glad you brought that up, because relying too heavily on the lab is a really common and potentially super dangerous misconception at the bedside.
Dangerous how?
Well, the golden clinical rule of toxicology is this: treat the patient, not the test.
Because the tests are too slow? Or are they actually inaccurate?
I mean, they can definitely be slow, but the much bigger issue is that standard point-of-care drug screens have massive blind spots. They're only looking for very specific chemical structures.
Ah, okay.
Yeah, so a standard urine tox screen might entirely miss synthetic opioids, specific benzodiazepines, or, newer designer drugs.
So our $1 million hospital lab equipment is essentially being outsmarted by, gas station potpourri and designer chemistry.
It's kind of wild, but it's entirely true. The illicit drug supply mutates way faster than our standardized tests can keep up with.
So if you wait for the test, you're losing time.
Exactly. If you delay empiric treatment like delaying giving Narcan or delaying airway support because you're waiting for a lab result that might just come back as a false negative anyway, your patient could die. You have to treat the immediate life threats based entirely on the physical toxidromes you actually see at the bedside.
Okay, so you trust your nursing assessment over a presumptive piece of paper. That makes perfect sense for acute intoxication. But recognizing physical signs is one thing, right? Decoding patient behavior is a whole different beast.
Oh, totally.
We hear the term drug seeking thrown around the nurses' station a lot.
We do, and honestly, it is a label that carries really heavy stigma, and it often severely degrades patient care.
So how do we reframe that?
Well, to really understand the behavior, we need to peel back that stigma and look at the actual neurobiology. True addiction is a primary chronic disease. It physically rewires the brain's reward system, flooding it with dopamine and encoding these incredibly intense compulsive cravings.
It's a fundamental change in the brain.
Yes, an individual with true addiction will continue to use a substance despite it causing significant, undeniable harm to their health or their life.
But the clinical evidence tells us that addiction is absolutely not the same thing as physical dependence.
They are completely different phenomena, and this is where the lines get really blurred at the bedside for nurses. Physical dependence is a normal, expected physiologic consequence of long-term use of certain medications.
Like opioids or benzos.
Exactly. Opioids, benzodiazepines, or even certain blood pressure meds. The body simply adapts its internal chemistry to the continuous presence of that drug.
Right.
So if you stop the drug abruptly, the body goes into withdrawal because its new chemical baseline has been disrupted. But that doesn't mean the patient is addicted in a behavioral sense. It just means their body has adapted to maintain homeostasis.
And here's where the practice knowledge gets really fascinating. There is a medically caused syndrome that mimics addiction perfectly. It's called pseudo-addiction.
Yes. Pseudo-addiction is a tragic iatrogenic syndrome, which just means it is inadvertently caused by medical treatment. Specifically, it's caused by the chronic undertreatment of pain.
Okay, so paint a picture of that for us.
Sure. So imagine a patient, maybe someone with advanced cancer, sickle cell disease, or a really severe trauma, whose pain is simply not being managed adequately by their current orders.
Because they are in pure agony, they start exhibiting behaviors that look, on the surface, exactly like addiction.
Right. They are intensely watching the clock. They're constantly buzzing the call light, asking when their next dose is due. They might be moaning, demanding higher doses, or even getting really angry with the nursing staff.
And a busy nurse who isn't looking closely at the underlying cause might just label that patient as drug-seeking.
Exactly.
It's kind of like if someone is dying of thirst in a desert and we label them a water addict because they're begging and screaming for a drink. We judge the behavior, but the reality is once you finally give them enough water, all that frantic, addictive behavior completely vanishes.
That is the perfect analogy. The defining characteristic of pseudo-addiction is that once the pain is actually adequately treated, the problematic behavior stops entirely. Yeah, and this is exactly why clinical guidelines explicitly warn against dosing pain medications solely based on subjective 1 to 10 pain intensity scores.
Because pain is incredibly complex, and asking a patient to pick a number out of 10 doesn't really tell you anything about their actual physiological state.
Right. Bedside care requires a comprehensive, holistic assessment. You have to look at objective measures like what is their respiratory status? What is their sedation level? Are they tachycardic?
You evaluate the whole clinical picture rather than just slapping a drug-seeking label on a chart and walking away.
Precisely.
So, we've seen how the body adapts to these substances, basically building a physiological dam to hold back the drug. What happens when that dam suddenly breaks? Because when a patient's supply is cut off, we enter the mechanics of withdrawal.
Yeah, and I noticed the medical field has largely shifted away from the word detoxification.
Right. The preferred term in clinical practice now is withdrawal management.
Because the word detoxification implies the simple, passive clearing of toxins like a juice cleanse or something.
Right. Which it definitely isn't.
Not at all. Withdrawal management acknowledges the reality. We are dealing with a complex, potentially violent physiological crisis that requires active, intensive medical and nursing support.
And the timeline and presentation of that crisis depend entirely on the substance. So let's start with opioids. Movies always depict opioid withdrawal as this incredibly dramatic, deadly event.
It is intensely miserable for the patient. I mean, truly awful. But unlike alcohol or benzodiazepine withdrawal, opioid withdrawal is generally not life-threatening on its own.
Unless they get severely dehydrated from vomiting or diarrhea, right?
Exactly. It basically feels like the absolute worst flu of your life.
So what exactly is happening in the body to cause that? The evidence talks about autonomic rebound.
Well, opioids suppress the central nervous system. When you remove them abruptly, the nervous system basically slingshots in the other direction. It just goes into overdrive.
So all the systems wake up angry.
Very angry. Patients experience severe muscle aches, diarrhea, nausea, excessive yawning, which is a weird but very real symptom, rhinorrhea, which is a heavily runny nose, and profound sweating.
How fast does that slingshot effect actually happen?
For short-acting opioids like heroin or fentanyl, the symptoms can start within a few hours, and they typically peak at the 48 to 72-hour mark.
And nurses actually have a tool for this, right?
Yes. To manage this objectively at the bedside, clinicians use a validated tool called the COWS, the Clinical Opiate Withdrawal Scale. It forces you to objectively measure things like resting pulse rate, pupil size, and observable sweating to guide your medication dosing. It takes all the guesswork out of it.
Now, contrast that with stimulants, like meth or cocaine. The withdrawal there is practically the physiological opposite, right? It's called the crash.
Yeah, this is where we see the profound impact of dopamine depletion. Stimulants flood the brain with dopamine, creating this artificial energy and euphoria. When the drug is gone, the brain's dopamine reserves are just completely empty.
So they just bottom out.
Totally. During the crash, the patient experiences crushing exhaustion. They might sleep for days straight. And when they are awake, they experience extreme dysphoria, severe depression, vivid and really unpleasant dreams, and a voracious appetite because their metabolism is frantically trying to recover.
And clinical experience shows that users often try to self-medicate this crash using what they call landing gear.
Yes, because the stimulant has them so wired and the impending crash makes them feel so psychologically awful, they often use alcohol, benzodiazepines, or opioids, the landing gear, to force their brain to slow down and sleep.
Which makes our job a lot harder.
Oh, immensely. This polysubstance use complicates their clinical presentation so much when they hit the ER because now you're dealing with overlapping toxidromes.
Right. Well, that brings us to alcohol withdrawal. And this is the one that can actually kill you.
Mm-hmm.
There is a specific phenomenon nurses really need to watch for called the kindling effect. What is the mechanism behind that?
So, to understand the kindling effect, you have to look at two main neurotransmitters. GABA, which acts as the brain's brakes, and glutamate, which acts as the brain's gas pedal.
Okay, brakes and gas.
Right. Alcohol enhances GABA, hitting the brakes, and it suppresses glutamate, letting off the gas. The brain adapts to chronic heavy alcohol use by decreasing its GABA receptors and increasing glutamate to try and maintain some kind of balance.
So when the alcohol is suddenly removed, the brain has barely any brakes, and the gas pedal is mashed all the way to the floor.
Exactly. That massive overstimulation causes tremors, severe anxiety, and seizures. And the kindling effect means that every single time a person goes through alcohol withdrawal, this chemical imbalance becomes more entrenched.
Wait, so it gets worse every time?
Yes. The next time they withdraw, the symptoms are actually more severe and they have a much higher risk of seizures. It's literally like adding dry kindling to a fire. It catches faster and burns hotter with every single episode.
That is such a brilliant way to visualize it. And nurses use the CIWA scale to monitor those escalating symptoms.
Mm-hmm.
But we also can't talk about alcohol withdrawal without mentioning Wernicke's encephalopathy. How does alcohol withdrawal lead to irreversible brain damage?
It all comes down to cellular energy. Wernicke's is a severe brain disorder caused by a massive deficiency of thiamine, which is vitamin B1. Think of thiamine as the spark plug that allows the brain to convert glucose into usable energy.
Okay.
Chronic alcohol use absolutely destroys the gut's ability to absorb thiamine, and it depletes whatever stores the liver has left.
So if a patient in alcohol withdrawal is given glucose without also being given intravenous thiamine,
Their brain cells literally starve because they don't have the spark plug to process the sugar you just gave them. This causes acute lesions in the brain, leading to confusion, vision changes, and a complete lack of muscle coordination.
and if you don't catch it.
If you don't intervene rapidly with IV thiamine, it progresses to irreversible memory loss, which is known as Korsakoff syndrome.
Okay, so we've identified the threats and the physiology. Let's move to bedside interventions. When you're managing these severe withdrawals, What does the evidence tell us is the real priority?
Well, the foundation is always supportive, humane care. Reassurance, a quiet, low-stimulation environment, and aggressive hydration are critical first steps. You are trying to help a central nervous system that is completely misfiring find its way back to homeostasis.
See, I'm trying to puzzle this out from a nursing perspective. Sometimes a quiet environment just isn't going to cut it. Like in stimulant toxicity, patients can become violently agitated, paranoid, and completely out of control.
Yeah, that happens a lot.
My gut instinct, if a patient is thrashing and trying to pull out their IV lines, is to just secure them. Physical restraints seem like the safest option for everyone in the room.
I know that is a very common instinct for newer nurses, but the evidence strongly pushes back against it. In the context of severe stimulant toxicity, physical restraints can actually be a death sentence.
Wait, really? What is happening physiologically when you restrain them?
Think about their internal environment. They are flooded with adrenaline and stimulant chemicals. If you strap them to a bed with leather or soft restraints, they will fight those restraints with everything they have. They're terrified and paranoid.
So they just keep pulling and fighting.
Yes. And this causes continuous, intense isometric muscle contractions.
Like they are running a marathon, but they are completely stationary against the straps.
Exactly. And that massive continuous muscle exertion causes lactic acid to build up rapidly in the bloodstream. Lactic acidosis. Their blood pH drops. Their body temperature skyrockets, leading to fatal hyperthermia and massive muscle breakdown called rhabdomyolysis.
Oh, wow.
Yeah, eventually this extreme physiological stress causes sudden cardiac collapse. The safe, evidence-based bedside intervention for severe stimulant agitation isn't a physical restraint. It's rapid chemical sedation, usually with intravenous benzodiazepines, to calm the brain and physically stop the struggling.
That is a phenomenal clinical pearl. Physical restraints in stimulant overdose can trigger a cascade right into cardiac arrest. Now, as if traditional drugs weren't complicated enough, we have to talk about the terrifying new frontier, which is synthetic drugs.
This is where bedside pattern recognition is being pushed to its absolute limits right now. Synthetic cannabinoids, often sold as K2 or spice, are not just strong marijuana. They are entirely different, highly potent chemical beasts.
How so?
They bind to receptors with incredible affinity. They cause extreme neurotoxicity. Patients present with violent seizures, profound psychosis, and acute kidney injury.
And linking back to our earlier conversation about the million-dollar lab equipment?
They don't show up. Standard drug screens miss them completely. You have a patient seizing and psychotic, and the urine test says they are completely clean. You just have to trust the toxidrome over the lab test.
The research also highlights kratom, specifically the highly concentrated extracts known as 7-OH. What makes 7-OH so concerning for bedside nurses?
Well, kratom hits the same mu-opioid receptors as traditional opioids, but these new concentrated 7-OH extracts are creating a uniquely brutal withdrawal syndrome. Patients describe a terrifyingly fast onset.
Faster than normal opioid.
Much faster. With traditional opioids, you might wake up the next day feeling sick. With 7-OH, the restlessness, the excessive yawning, and a profound rising sense of psychological dread set in within mere hours of their last dose.
That sounds miserable.
It is. The cravings are relentless, and they experience severe stomach cramps that really outpace traditional opioid withdrawal. It's a rapidly evolving landscape.
Which really brings us to our final core topic: pain management in patients who already have a substance use disorder and recognizing the unseen patients around us.
Yeah, this is a really complex area of harm reduction in acute care. Let's look at a patient who is actively in recovery and they're taking opioid agonist therapy, or OAT, so medications like methadone or buprenorphine.
Okay.
If that patient is admitted to the hospital for surgery or a severe trauma, it is a clinical imperative that their baseline OAT is maintained.
See, I really need you to clarify this for me, because this confuses a lot of people in practice. If my patient takes methadone daily, my gut says they're already heavily medicated. If they break their leg, I'd actually be terrified of giving them more opioids and causing an overdose. Shouldn't they need less pain medication?
It makes complete sense on paper, I totally get that. But in reality, it's the exact opposite. OAT prevents withdrawal. It does not treat acute pain. Because these patients take these medications daily, they have a massive tolerance. But more importantly, they often suffer from opioid-induced hyperalgesia.
Meaning their nervous system becomes hypersensitized to pain.
Exactly. Chronic opioid exposure actually rewires the pain pathways so that they perceive pain more intensely than a naive patient.
Oh, wow.
Yeah. So they actually need significantly higher and more frequent doses of standard short-acting pain medications just to achieve the same level of relief as a patient who doesn't take daily opioids.
And if a clinician abruptly stops their methadone while they are in the hospital because they are afraid of oversedating them,
You plunge them into acute severe withdrawal on top of their acute physical trauma. It is a recipe for disaster. It drastically increases the risk that they will leave the hospital against medical advice and return to illicit substance use just to find relief from the agony.
it really requires immense empathy and just a solid understanding of the neurobiology to validate their pain and treat it aggressively.
Yeah.
But as we wrap up today, clinical experience points us to a very sobering reality. Sometimes the person suffering from a severe substance use disorder isn't the patient in the bed. Sometimes it's the colleague standing next to you.
Yeah. The stress of healthcare, the vicarious trauma, and the sheer accessibility of controlled medications make healthcare professionals incredibly vulnerable. It is vital to watch for the subtle behavioral signs of impairment or diversion in your own workspaces.
And what we know from practice is that it rarely looks like someone stumbling down the hallway or slurring their words. It's much more subtle than that.
Very subtle.
It's the colleague who consistently volunteers to give pain meds to other nurses' patients. It's a sudden preference for night shifts with less oversight. It's excessive, unexplained drug wastage, frequent long trips to the bathroom, increasing isolation from the team, and yes, those pupillary signs we talked about at the very beginning, pinpoint or dilated pupils while on shift.
Treating substance use disorder requires us to replace judgment with profound clinical observation. It really requires courage to speak up and advocate for safety, whether the person suffering is wearing a hospital gown or wearing scrubs.
So let's look at the through line of what we've unpacked today. We've learned that standard drug screens can be dangerously deceptive. We have to rely on toxidromes and treat the patient, not the test. We've explored the difference between the neurobiology of true addiction and the iatrogenic tragedy of pseudo-addiction. We've walked through the escalating crises of withdrawal from the opioid slingshot effect to the dopamine crash of stimulants and the deadly glutamate-driven kindling effect of alcohol. And we've seen why physical restraints can be fatal in stimulant toxicity and why understanding opioid-induced hyperalgesia is crucial for harm reduction.
It really emphasizes how dynamic and intellectually demanding bedside nursing actually is. You are constantly reading physiological clues in real time.
It absolutely is, and it leaves you with a lot to think about as you walk into your next shift.
It does. And, if we connect all this pattern recognition to the future of medicine, it raises a really fascinating possibility. Well, as designer drugs and synthetic analogs continue to mutate way faster than our laboratory drug screens can possibly detect, maybe the future of toxicology isn't a better urine cup. Imagine a wearable, continuous patient monitor that doesn't just read heart rate, but actually uses AI to detect the specific microtremors of the alcohol kindling effect, or the exact autonomic sifts of a synthetic toxidrome before a human clinician even walks into the room. We might soon be training algorithms to read the very toxidromes we discussed today.
That is an incredible thought to end on. Technology actually learning our bedside intuition. Thank you for joining us today. Keep learning, keep observing, and stay curious.